Lagos to be precise. You're welcome to today's edition, part 5 of Demystifying Glaucoma, the past, present, and the future. So just in case you're joining us for the first time, you're welcome to the YouTube channel where I teach on everything that pertains to optometry and eye-related issues. So we have been running a series on glaucoma so far. So we've run part 1, part 2, part 3, part 4, and today is the part 5. So just in case you've not followed through the part 1 to up to 4, I urge you to please go and subscribe, go and like, go and share, and watch the videos. And don't forget to send me your comments. It will be very, very needful for the growth of this channel. So today we are going to be looking at a very important topic, which is glaucoma, like I've said. And the aspect of glaucoma we are looking at this period or in this session is the treatment of glaucoma. And we are going to be looking at selective laser trabeculoplasty. What is it all about? And what does it have to, how does it improve the patient well-being in the 21st century? So we're going to be focusing on the introduction, the trabecular meshwork. We're going to be looking at the argon versus the selective laser. We're also going to be looking at the mechanism of action of this selective laser trabeculoplasty, SLT. We're going to be looking at the contraindications, the pre-test, the procedure, how it is being done, the common complications, the post-procedure benefits, and then conclusion. We'll call it a day for today's session. So quickly, introduction. What is SLT per se? First of all, we need to understand how lasers work, because it is a laser procedure. So lasers are created where atoms or molecules are excited. So every time atoms or molecules are excited, lasers are being produced, and which results in the release of photons. So laser is an acronym for light amplification by stimulated emission of radiation. So when you amplify light and then you stimulate it to be emitted, it is what we call laser. And then trabeculoplasty is a treatment for primary open angle glaucoma, and it has been successful in about 75 to 80 cases of patients whom it has been done on. So it is a very, very successful procedure, and everyone should know and be informed about it. So there are forms of laser trabeculoplasty, such as the argon laser, the selective laser, the micropulse laser. These are basically 3 forms of laser we have in our reach today. And then ALT, that is the argon laser technique, was developed in the late 1970s. So it was virtually one of the first advancements in laser in treatment of glaucoma. It was developed in the late 70s, but then selective laser trabeculoplasty was developed as an alternative to ALT, that is argon laser, and it was developed by a man called Tina in the mid-90s. In the mid-90s, him and his team, they developed the SLT. So it is recommended as the first line of treatment in up and primary open angle glaucoma. SLT is the first line of treatment every time we are looking at ocular hypertension or we are dealing with cases of primary open angle glaucoma. So it is not first the drugs, but the laser technique is the first line of treatment. But then your doctor is in the best position to determine if you are, will I say, qualified in quote for SLT. Are we together? So it uses a Q switch, double frequency, and YAG laser. So that is what the SLT uses, and it has a short laser pulse duration of 3 nanoseconds, shorter than the tissue thermal relaxation time. So it means that it can do the work quickly and come out without the tissues being stretched or being stressed by the laser that has been emitted to it. So having said this, let us quickly look at the trabecular meshwork. What is it all about? So trabecular meshwork is a sieve-like structure at the angle of the anterior chamber. So in the eye, it's also called the anterior chamber and the posterior chamber. Remember, aqueous humor, which is being produced from the pars pliccata, which is the part of the ciliary body, it flows from the posterior chamber bathes the lens and then flows out through the anterior chamber. So the trabecular meshwork is a sieve-like, it's like a sponge in appearance. It's a sieve-like structure at the angle of the anterior chamber, and 90% of aqueous humor drains through the trabecular meshwork, 90%, and then 10% and others drain through other pathways. So the trabecular meshwork is composed of three parts. Three parts make up the trabecular meshwork. The first part is the uveal meshwork. The second part is the corneoscleral meshwork, and the third is the juxtacanalicular meshwork. So these are the three parts that make up the trabecular meshwork. And then if when I'm going to share this slide, you're going to appreciate it better because you're going to see the images and how these things look like. So we want to compare ALT, that is the argon laser, versus the SLT, selective laser. So we want to compare them and know why are we saying we prefer SLT to ALT. Now, crater-like tissue damage destruction was seen in with scanning electron microscope in ALT, but not in SLT. What this means is that after the laser has been employed on the tissue, there is this crater-like tissue damage. So there is a tissue damage in the trabecular meshwork, which was more obvious under the microscope, but was not seen in the selective laser trabeculoplasty. And again, ALG uses a 514 nanometer argon laser on half of the meshwork circle, while SLT uses 532 nanometer YAG laser. So and again, ALT cannot be repeated on the first half of the meshwork. What this means that you have 360 degrees. Now, most times the ophthalmologist will want to do 180 and then subsequently do another 180 below. This means that if 180 was done superiorly, it cannot be done again superiorly, it must be done inferiorly. So because of the damage caused in ALT, are we together? And then the pulse energy of SLT is about 100 times lower than ALT. So SLT is just like you having a minor invasion, yet very, very effective. But SLT, you are having a minor invasion but very, very effective. Why ALT is like putting so much work on the trabecular meshwork. So both of them have similar results in lowering IOP, but then in terms of thermal or tissue destruction, SLT is better. Now, there are three mechanisms of action of how SLT work. The first is the mechanical, the second is biological, and then the third is the population mechanism of action. So in my slide here, I have pictures of how the trabecular meshwork looks before and after when the laser was employed to it. So when I share the slide, do feel free to DM me to send you the slide so I can appreciate what I'm teaching. So what are the contraindications for SLT? What are the things we see and we say we don't want to do SLT in the clinic? So these are the things your doctor will see and say, okay, in view of this, I don't think you're a good candidate for SLT. The first is angle closure glaucoma. It is a contraindication for SLT because in angle closure, the angle of the anterior chamber is closed. So we don't want to do SLT because we want to have a good view of the trabecular meshwork in order to project the laser to it. Are we together? And then when we have a case of neovascular glaucoma, in neovascular glaucoma, we don't want to, it's a contraindication for glaucoma. Another contraindication for glaucoma is inflammatory glaucoma. So in inflammatory glaucoma, you see when there's an inflammation of the uvea or whatever it is that leads to glaucoma, it is not a good case to employ for SLT. Another contraindications for SLT is synechia. Synechia is the adhesion of the iris to the cornea or the iris to the lens. So it can either be posterior synechia or anterior synechia. So in these cases, glaucoma is not, SLT is contraindicated. And again, previous non-response to SLT. So when there is a previous non-response to SLT, we don't want to involve, or we don't want to involve the patient in such a case. So it's important that your case history is properly done, and then you ask the patient if he has done SLT before. We want to know what was the outcome. Maybe he did it maybe in a different clinic, and he wants to try out in your own clinic. So we want to know why didn't it work out, and then what we need to do. Again, another contraindications to SLT is advanced glaucoma. Advanced glaucoma is a contraindication to SLT, and again, history of laser trabeculoplasty failure when it was done before and then it failed. We want to not to do it again. And again, congenital glaucoma is a contraindication for SLT and apprehensive patients. So there are patients who are apprehensive. Only the mention of laser, they begin to fidget. They begin to assume that it's going to be something that is going to destroy their eyes. So because the procedure will require you to be still, it will require you to be focused. Are we together? So there are patients who, under such condition, their body begin to shake normally. So they are not good candidates for SLT. So having said this, what are the tests we need to do in order to, before we book or before a patient goes to do the procedure of SLT? The first is the visual acuity. For sure, we want to know what the patient is seeing. We want to know what the visual acuity simply means what the patient can see with each eyes upon arrival to the clinic. So we want to take the visual acuity, both the aided and unaided. And again, tonometry, very, very important. We want to know the eye pressure, because there can be a spike in pressure immediately after the SLT. So it's important that the pressure of the eyes is noted. Also, we want to evaluate the anterior chamber. For sure, like I said earlier, if the anterior chamber is shallow, it might not be a good candidate for SLT. Again, pupillary constriction. So we want to make sure that the pupil is fine in order for we to we want to constrict the pupil before we take for SLT. And again, anesthesia. So because it's a laser technique, the eye needs to be numbed in order to take the technique. So what is the procedure for SLT? So it's an outpatient treatment. It means that the patient can walk in and then do the procedure and go back to his workplace. So it's not a procedure that you will do and then you have to be booked, or you have to stay put for days before you go out to your normal activities. No, it's a procedure that you can do, and after 1 hour, you go back to your place of work. So the eyes are numbed with eye drops, with numbing drops. The eyes are numbed, and then the procedure is explained to the patient. It is important that before we do any test in optometric practice, we want to explain to the patient what we want to do and how we're going to do it, so that they are on board with what we are doing, because sometimes you might need to come close to the patient and the patient might not feel so comfortable with that. But then once you explain the test to the patient, you let the patient knows what you are doing, he trusts you and he feels comfortable. So the procedure is properly explained to the patient, and the patient is seated facing the doctor who is going to perform the SLT, and then gonioscopy is done. Gonioscopy is done to ensure that the anterior chamber is open, so preferably with zero magnification. So it's important that we do gonioscopy in order to look at the anterior chamber very well, because it is laser, and in laser we want to see the sites in which the laser will go to before we begin the procedure. So the laser is directed to the trabecular meshwork to open up the canal. Remember, like I said earlier, the aqueous humor, which is produced by the pars plicata, flows from the posterior chamber and then drains out in the anterior chamber. Now, because the trabecular meshwork is sieve-like, so there can be some accumulation of aqueous humor there. So we want to open up those pores a little bit, so that the aqueous can drain out quickly as possible. So about 75 to 100 laser pulses are applied each lasting about 3 nanoseconds. So this is subjective to the doctor who is doing it. Every doctor have their own means of, or their own modus operandi, but for theoretical purpose, about 75 to 100 laser is applied each, and then 180 degrees or 360 degrees are treated in one therapy. What this means is that you can decide to do a 180, or you can decide to do a 360. Remember, in argon laser, you cannot do 360 at once, because once it's done, it should not be done again because of the crater-like destruction it causes. So in argon laser, we want to do 180, and then subsequently, in months to come or years to come, we do the remaining half of 180.